Thanks again. I appreciate the opportunity to get up here twice. You guys haven't had enough of me yet. So I want to talk again somewhat practically about how we think about when to use immunotherapy. And I'll start this by saying we really don't know yet. But we're going to talk about the ways we can do it and how things might go forward, and just point out that this is an area of active research that we really do need to learn more about. So the themes of my talk today are going to be to try to identify the times in treatment when immunotherapy could be given, review rational combinations of immunotherapies with other treatments, and I know that's a question that's come up a couple of times, and to discuss factors that might suggest whether or not the immunotherapy will work, and we refer to them as biomarkers, and so this will be a good add-on from the talk that you just heard. So before I get started, it was suggested that maybe it would be a good idea to just talk about what the available immunotherapies for each of the three cancers that we were focusing on today are. So for melanoma, there are cytokines interferon alpha and interleukin-2, and antibodies ipilimumab and pembrolizumab. In kidney cancer, the cytokines include interferon alpha and interleukin-2, and the antibodies include bevacizumab. And in lung cancer, there are antibodies that are approved, including bevacizumab. The following two are not approved, although there's clinical trial data that suggests that they could have efficacy, including cetuximab and ramucirumab. So what are the different settings in which we could give immunotherapy? And the first of these that we could talk about is neoadjuvant therapy, or essentially therapy we would give prior to definitive surgery. So I want to get all the lingo down here so we don't get lost in terms of what we're talking about. At the bottom of this figure, you see a clinical trial design of a neotherapy approach to the treatment of breast cancer. This was a now famous trial called the NeoAlto trial. And basically what you can see is in the trial, patients got randomized to different arms. They got different kinds of chemotherapy. Then they all got surgery and then got more treatment. So the neoadjuvant part was they were treated before the surgery to see if that could help improve the quality of the surgery, with the goal of shrinking the tumor before surgery in hopes of increasing the likelihood of a complete resection. Adjuvant therapy would be therapy after surgery. So the goal here would be to generate an immune response that could destroy any remaining cells after the patient had already had surgery. And here you see a clinical trial design for an adjuvant therapy study where all the patients have resection of the tumor, then they get randomized and they get various different kinds of chemotherapy to see which one's best after surgery. And finally, there's treatment in the recurrent setting. And the goal here is to try to induce the immune system to try to get the cancer that's spread back under control in the hopes of inducing a complete and long-lasting tumor response. So those are really the three areas we could see the utility of immunotherapy in the future. It's important to sort of point out again that this is a complicated process. So you heard earlier that the adaptive immune response, the T and B cells, are very specific for different infectious and cancer molecules, and up to about 2.5 times 10 to the 7th number of molecules can be observed or can be recognized by the immune system. In the situation where you're treating not too much cancer, that can be really important, and we're going to talk about that here in a little bit. But this is some data from the National Cancer Institute where they used cells that they isolated that were specific to the molecule in the cancer, and they were able to infuse them in the patient and get the cancer to shrink, and when the cancer started to grow again, shrink again. So they were able to get the actual cell that was specific to the tumor and infuse it. So the immune system has to be able to see the cancer molecule in order to mount that immune response. So these cells were specific for that kind of cancer. But if only single cells are available to the immune system, they may just not see it. There may just not be enough cancer cells left. And that could influence whether or not you would want to give the immunotherapy before or after surgery. Larger tumors have millions of cancer cells, so that you might propose that would make it more likely that the immune system could see that. And we saw earlier from Dr. Atkins that if immune cells are able to traffic into the tumor, you're more likely to have a potential benefit. Then at the same time, however, the tumor makes molecules that can allow it to escape from the immune system and therefore may dampen the immune response. So again, we don't know the answer to this, and all of these questions are sort of floating in our head and could influence the results of clinical trials in the future when we think about whether or not this is a good approach. And I'm going to go back and just explain this one more time as well. How does the immune system actually respond? I'm breaking it down into three simplistic categories, but basically the danger signal has to alert the immune system, and those antigen-presenting cells or dendritic cells have to notice and take up the antigens from the cancer. Those dendritic cells need to go to the lymph node and show that to the other immune cells, the T cells, and those T cells then need to go back and try to kill the cancer. okay? And this can get disrupted in a lot of different ways, and all these different pieces have to work. So what would the pros and cons be of these different approaches? So the first one we talked about was a neoadjuvant approach. In other words, treatment before surgery. So before surgery, the pros could be to allow evaluation of the response of the treatment before the surgery. In other words, is the treatment shrinking the tumor, suggesting that maybe it would work later? Could it reduce the amount of tumor that has to be resected at surgery? So you could just imagine that a smaller surgery is better than a larger surgery. And could it possibly even kill any cells that had already gotten away? At the same time, any cells that had gotten away may have different mutations that you've heard so much about. And so if you mount an immune response against the primary tumor, it may be that that works and yet still doesn't treat those cells that already got away. So I'll show you a neoadjuvant study in bladder cancer that's rather famous at this point. This is a study done at the MD Anderson where patients with bladder cancer were diagnosed. They initially were treated actually with ipilimumab for a dose, and they were able to collect blood from those patients to try to look at, are we seeing activation of the immune system? All those patients then underwent surgery, so they could then compare this biopsy to this surgical specimen and see, did the immune cells go into the tumor or not? And then they were able to continue to follow those patients over time. So this sort of study design is really great for generating the kind of data we talked about. It was just alluded how a lot of trials in the metastatic setting are requiring biopsies at baseline and on treatment. This is an avenue for which we could get a lot of data in the context of standard practice. So obviously, patients are going to get diagnosed and they're going to get surgery. So this is a way to sort of encapsulate all of that and collect more information. And what they found in this study was that treatment with ipilimumab in these patients with bladder cancer was able to upregulate a number of molecules, one of which of particular interest is a molecule called ICOS, which is one of those brake switches, and is another target for cancer immunotherapy drug development. I'll also just highlight this trial. This is an ongoing trial at the MD Anderson right now. And in this trial, patients who have kidney cancer are screened for the trial. They're randomized to 3 arms where they get different immunotherapies: anti-PD-1 with nivolumab, anti-PD-1 with anti-VEGF with nivolumab and bevacizumab, or anti-PD-1 and anti-CTLA-4 with nivolumab and ipilimumab. All patients get surgery, and then they all get anti-PD-1 thereafter. So you can just imagine the wealth of information that we can get from this sort of approach where you can compare all these different tumor specimens. You know, obviously, everybody who's a patient in this room realizes we collect a lot of blood. We can analyze all of that in the context of our treatment and hopefully predict which of these therapies could be the best in the future. So what about immunotherapy after surgery? What would the pros and cons of that be? So a pro would be that you didn't potentially get a treatment that delayed your surgery, because obviously we want to give you a treatment that didn't work and then your cancer got worse before your surgery. We may actually be able to tailor any subsequent treatment based on what we find in your surgical specimen. So there might be characteristics about your tumor that which you might find that might suggest that a treatment in the future might help. The cons, however, are that maybe you didn't need anything more than surgery. So if you get treatment after surgery, maybe you get a side effect and you never needed that treatment anyway and the surgery had cured the tumor. Also, it may be that there's a limited amount of that tumor antigen floating around and the immune system isn't able to mount a response against it because it's just not enough of it there. And there's also sort of an open-ended question with some immunotherapies. If they really work, do you need to give them after surgery, or can you wait until the tumor does come back? Because if the immune system really works, and we all believe it does, but it should work later too. But I'll highlight that this is quite complicated. So there have been, for a long time, attempts to try to harness the immune system in the adjuvant setting, because it was thought if there was less cancer, there would be less of those inhibitory mechanisms in place. So in lung cancer, I'm highlighting a trial here of a vaccine approach directed towards a molecule called MAGE-3. And you don't have to obviously memorize all the details here, but suffice it to say that they randomized patients, they made sure that the tumor actually had MAGE-3 in them, they started to vaccinate the patients, and they could tell they were getting a vaccine response against this MAGE-3 molecule. The phase 2 trial looked pretty good, but unfortunately, even though they had the right protein and they had the vaccination and it looked like it was working, the patients didn't live any longer because of it. And that may go back to the specificity of the response that we need. Again, everybody's tumor is a little bit different with different mutations, and everybody's immune response, if it's going to work, needs to be specific for your own body or for that patient's body. In melanoma, we've had some recent success, we think, with ipilimumab in the adjuvant setting. I'm going to go over that data, but again, highlight how it's a little bit nuanced. So this was recently reported at ASCO this year of using ipilimumab at 10 milligrams per kilogram in the adjuvant setting. So high-risk melanomas were randomized to either get induction therapy with ipilimumab or to get a placebo, and then went on, got the 4 doses, and then went on to get maintenance therapy thereafter. This is the relapse-free survival curve, and I'll just highlight, maybe I will, there we go, that this was a positive trial, meaning that it reached a statistical significance that it took longer for the patients who got ipilimumab to have a recurrence of melanoma than those patients who got placebo. So that sounds great, right? So we should start doing this, right? Well, what were the downsides? Well, the downside was that patients who got the ipilimumab got a lot more side effects. And when we're talking about giving treatment, you know, a number of treatments that patients get in the metastatic setting for cancer, we tolerate side effects because we're dealing with cancer that's growing in our bodies. In the adjuvant setting, you don't have cancer. So if you get a bad side effect, you may not be quite so enthusiastic about the treatment. So half the patients came off of this clinical trial because they had side effects from ipilimumab. One interesting feature of this trial was that we found that the number of patients receiving more than 1 maintenance dose, so again, the standard treatment is 4 doses, the number of patients that went on to receive another dose afterwards was only 42% of the patients. And you remember that this was a positive trial, so it did take longer for the melanoma to come back, which actually to me suggests that maybe those 4 doses are actually what patients need in order to get the benefit. So that is a useful thing that comes out of these kinds of data. But again, I'll highlight that if you had your melanoma resected, there was a percentage risk that it wasn't going to come back. And if you were one of the people who had severe colitis, 7.6%, or the development of hypophysitis and you need to take steroid replacement the rest of your life, or you had liver toxicity, you may not be quite as enthusiastic about it. So these are nuanced issues, and we have to consider them carefully. So just because we can give a drug doesn't mean we necessarily should give a drug. And it needs to be discussed with your oncologist, and we need to interpret these kind of data carefully. So what about treatment of unresectable cancer? So after your surgery, unfortunately, the tumor does come back. What about that situation? And I would just point out that, and I think all would agree with me, at the time of a recurrence, the first thing to do is stop and think about what's important here. What are the goals of care? What are the family issues? What are the patient's expectations about what we're going to do? And discuss those clearly with the doctor instead of just diving into the treatment first. In terms of treatment, how should immunotherapy be given in relationship to other treatments? Should we give it before chemotherapy, during chemotherapy, or after? A number of combination approaches have been tried with targeted therapy agents, as well as chemotherapy and radiation. There are many more in development. Again, all the standard drugs that are available. Some of these combinations could include targeted therapies like BRAF, VEGF, or EGFR inhibitors, specific to whichever kind of cancer you may be dealing with, melanoma, kidney cancer, or a lung cancer. And chemotherapy has been proposed that some may have immunological properties that might also stimulate the immune response. And finally, radiation approaches have also been highlighted in this meeting already.